Welcome back, everybody. Today we're going to talk about ankle and foot. This is a quite complicated or complex feature in our body for obvious reasons, but we will discuss them very shortly. Just so you know, give you a heads up, we are talking really about 28 bones and 29 joints. So it is very complicated part of our body. So let's go to the next slide. And there we have the functions of the ankle and foot. So of course serve as a base of support, but we talked about that already. Act as a shock absorber, adjust very well to irregular surfaces. So we can enjoy walking on the beach, we can walk on the asphalt or concrete, but we also can hike in the mountains. So all those uneven terrains are well absorbed by our feet, of course assuming that our feet are healthy. Control and stabilization of leg on the planted foot. That's going to be very important, for example, when we are walking the stairs up or down, right? We planted very firmly the foot on the surface and we raise our entire body. Elevation of the body. For example, when you stand on your toes, when you jump, when you run. Operate machine tools, of course, like it or not, we all driving the car or our cars, and substitute for the hand function. A lot of times when the small babies are born with severe deformities or upper extremities, or sometimes they're born without upper extremities, they adapt by using their feet the way we're using our arms, and they can actually be very, very skillful at that. So people can wash themselves, dress themselves, even drive the car and write papers. So of course the older you get, that would be very, very difficult to accomplish. For example, if I lost my arms at this stage in my life, my feet can just walk and run, but nothing else. Anyway, let's go to the next slide. And the next slide, you can actually see the bones of the ankle, and the ankle joint. It gets a specific name, is called talocrural joint, Talocrural. So this is really the articulation between three main bones of our ankle, and those of course are tibia, fibula and talus. And remember fibula wasn't that significant in the superior side of the bone. It really acted only as a support for tibia and help with the proper alignment of tibia. However, in our ankle, as you can clearly see on this picture, fibula plays much more important and actually active role. Okay, so let's go to the next slide. We can divide the foot into three main parts, which is hind foot, talus, and calcaneus. Calcaneus is this the biggest, the largest, the heaviest bone, the most massive bone in our foot. It's all the way to the back. Talus, we already talked about talus, very, very important bone for the ankle joint. Midfoot consists of navicular, cuboid, and cuneiforms, 3 of them, and forefoot, metatarsal, 5 of them, and phalanges, 14 of those. Okay, let's go to the next slide. And here we are. You can clearly see that rear foot, midfoot, and forefoot, and all the bones which we just mentioned are colored differently for easiness of recognition where they are. Okay, not much else to say on this slide, so let's go forward. Let's talk about arches. Arches, of course, are very, very important, and we talked about importance of the arches when we were talking about our hands. So similarly, feet have arches as well, but this time one longitudinal and one transverse, and you can clearly see them on those drawings, and the slide is titled Arches in Foot. So it's I don't have to explain anatomy of it because you can clearly see it. However, from the kinesiological point of view, we have to understand the importance of those arches. And for those of you who suffer the condition which the arches are flatter or more pronounced, you know exactly what I'm talking about when I say discomfort and pain. People who are suffer either from arches which are too prominent or too steep, cannot stand on their feet for prolonged period of time without being in discomfort and pain. But similarly, the people whose arches are much flatter will suffer from similar symptoms. Why arches are so important? Well, we already discussed that, but just to refresh your memory, if you will, it's very important for distribution of the weight. And after all, feet are bearing all the weight of our bodies. So it is crucial that the distribution of the weight goes side to side and back to front evenly, so we don't suffer discomfort, pain, etc. Okay, so let's go to the next slide. Major ankle joints, talocrural joint we already discussed, tibia, fibula, and talus. So collectively, this joint is called talocrural joint. Then we got subtalar joint between calcaneus and talus, and transverse tarsal joint, calcaneus with talus, navicular, cluboid, and cuneiforms, and you can all spot them on the left hand side when you got a drawing of the foot. Again, authors chose to use colors to differentiate the part of the foot, so it's very easily recognizable, and you can find that for your own sake. Again, I like to talk about it as this mental picture, or this mental map. So when we are talking about those features, you can clearly see where is what and understand what we're talking about. So let's go to the next slide. Okay, so this is a dorsiflexion or plantar flexion. What's going on in the talocrural joint? We talk about that joint, that this is the most important joint in the foot. So what's biomechanically or kinesiologically speaking, what's going on within the joint? So dorsiflexion and plantar flexion, as you can recognize, we have no extension in the foot, right? So in the wrist we had wrist flexion, wrist extension, but in the foot we do not. We simply refer it as a dorsiflexion, foot goes up, or plantar flexion, foot goes down. Okay, so dorsiflexion, during this movement the talus rolls forward and simultaneously slides to the posterior side, and you can clearly see that on this drawing. Dorsiflexion elongates the posterior part of the capsule, also Achilles tendons and calcaneofibular ligament, which is also very clearly shown on the left hand side of the slide. So if you dorsiflex, it's easy to remember everything what is on the back. It's actually start to become taut, elongated, tight, when everything what is up front becomes lax. Okay, so whatever we said about dorsiflexion just simply reverses in the plantar flexion. So all the features such as anterior part of the capsule and anterior talofibular ligament becomes taut, when on the back the Achilles tendons and the posterior capsule becomes slacked or laxed. Okay, but by now we well understand how all those features such as tendons of the muscles and joints, capsule of the joints to be more precise, and of course ligaments behave when we are flexing or extending. Okay, let's go to the next slide. And again we have a nice view on this time on the subtalar joint. Okay, so we have drawings and pictures all mixed up over here. So we have A, B, C, D, and E. Right, so A and B, those drawings on the top shows us the axis of rotation for the subtalar joint. Okay, so clearly, as you can see, you got medial view and superior view, and then axis of rotation, the red line, it's somehow inclined, right? And that's a very important feature for our foot, because this axis of rotation in subtalar joint would allow us to do pronations and supinations, or eversion and inversion of the foot. So there are very specific numbers assigned to those angulations of the axis of rotation. So 42 degrees from the horizontal plane and 16 degrees from the sagittal plane. And you can see it, you got the medial view, 42 degrees. And 16 degrees is on your right hand side, picture or drawing B. All right, so again, this is very important. Otherwise, our foot would not be able to do what it does, and this is only, we're talking only about subtalar joint, right? So this axis of rotation relates exclusively to subtalar joint. Okay, so why is this important? We can take a look at picture C. This time is the picture on the bottom of the screen to the left, and you can see again that red line which represent the axis of rotation of the subtalar joint. So on this picture it's clearly shown that yes, indeed, the line goes up and to the side. Okay, why this is important? Well, because we can do movement which sometimes they call it, we can pronate the foot or supinate the foot, but also known as a terminology eversion and inversion. And of course you can see on those pictures exactly what the authors mean by eversion, inversion, or pronation and supination. And again, you can use this interchangeably. However, with foot, I like to personally refer it as a eversion and inversion. It just works better for my personal kind of mapping in my brain the terminology and the movement, etc. Okay, so let's go to the next slide. And this is just a simple picture of how the supination and pronation or inversion and eversion actually work. How does it look in real life situations? Okay. You got other joints, of course, involved. You got all the joints really involved in the movement. It's just a matter of which one is involved more than the others. But in reality, every single one of the joint related to ankle and your foot, it's actually working in its own way, right? So the two joints together, transverse tarsal and subtalar, are responsible for control of those particular movements, supination and pronation. So in reality, the main two joints are transverse tarsal and subtalar. Okay, what else I would like you to know over here? Okay, one more piece of information. Talocrural joint, the one we already discussed, is primarily responsible for dorsiflexion and palmar flexion. One more time. Talocrural joint, the one we already discussed previously, is mostly responsible for dorsal and plantar flexions. But again, as you can appreciate on this picture, and the slide is titled Movement at the Transverse Tarsal Joint, that in reality all the joints are working. There is no way one joint can work and the other does not. One movement affects everything, but we are discussing which joint is the primary mover. Same like we're talking about muscles. We know that every movement, practically every movement, involves set of muscles, more than one muscle. But we are going to talk primarily about the primary mover, and then the rest of the muscles are going to be called secondary or even tertiary muscles or movers. Okay, let's go to the next slide. Joints in the foot, mid-tarsal joint, talus and navicular, tarso-metatarsal joint, distal tarsal row and base of metatarsals, metatarsophalangeal joint and interphalangeal joints. So clearly you can see the evidence that foot and hand, anatomically speaking, have the same features. Of course, the foot looks different and acts differently than our hand, but this is because of evolution. When men started to walk on the ground, the role of the foot had to change. Right? The monkeys or the primates' feet work as well as the hands. Okay. Again, because of the environment, right, where they live. Okay, let's go to the next slide. Joints of the foot, and you got another nice drawing over here, so you can find all the features we just discussed about the foot in this on this particular slide titled Joints in Foot. Let's go to the next slide called Landmarks, and you got medial lateral malleolus, Achilles tendon, and calcaneus. All of those are very important, of course, landmarks of the ankle, but for our purposes, the medial malleolus and lateral malleolus are perhaps more important, if I may say more important. Not really true, but let's just assume for our purposes they're gonna be more important than the other features, because we do measurements of the foot range of motion, and we measure the length of the lower extremities, for example, using those bony landmarks are our point of references. So medial malleolus and lateral malleolus is used in, for example, goniometry, or with the tape measuring the length of the entire lower extremity. Okay, let's go to the next slide. And we got some muscles. So ankle plantar flexors, gastrocnemius, soleus, and tibialis posterior. Let's go to the next slide. Tibialis anterior, what does it do? Dorsiflexes the foot and inverts the foot. Foot inversion is caused by tibialis posterior. Foot eversion is caused by peroneus longus and peroneus brevis. Hallux and toe MP flexors, lumbricals, and flexor hallicus brevis. Hallux and toe DIP and PIP flexion, and you got flexor digitorum longus, flexor digitorum brevis, and flexor hallicus. Hallicus and toe MP and IP extension, and you got set of muscles over here. And we finally got to the slide called muscle actions. Okay, so let's take a look at this drawing, and you can and this time the foot is divided by those red lines representing axis of rotation of important joints. Okay, so you got this one red line going up, down, or down, up on your screen. This is axis of rotation of subtalar joint. And then you got another red line running from left to right or right to left, and this is axis of rotation of talocrural joint. Okay, so Well, why this is important? Biomechanically it is, because depends on which side or which quadrant of the foot the muscle is actually inserted, the muscle contracts and the foot is going to behave accordingly. So again, on the top left you got muscles responsible for dorsiflexion and inversion. On the top right, is dorsiflexion eversion. On the bottom left, plantar flexion inversion, and the bottom right, plantar flexion eversion. Okay, let's go to the next slide. Common peroneal nerve. Okay, well, very good knowledge to have when, I'm not saying if, but when you are going to encounter patients with low back pain. Okay, so the sciatic nerve, remember the sciatic nerve, we talked about that in the previous video, divides into two nerves, and we talked about that as well. I gave you already some of that information, so you are well prepared for the bits of information I'm gonna add to it. So approximately at the knee level, the sciatic nerve divides, and one nerve goes into anterior side of the leg, and it's called common peroneal nerve. And further divides, of course, into superficial peroneal nerve and deep peroneal nerve. The other nerve goes into posterior side of the leg and is called tibial nerve. So combined, they supply all the muscles of your lower extremities. These primary nerves have also terminal branches, and you can open your book and look for those terminal branches. Why we call it terminal? Because there is no more divisions. So the terminal branches actually are attached to the muscles and supply, of course, those muscles. So I advise you to open the book and just take a look how this whole thing looks like, again, to kind of create that mental picture for yourself. Okay, so you can distinguish the medial plantar nerve, for example, you can see on the drawing, lateral plantar nerve, and also sural name. The sural name is a little bit different because it is a sensory nerve, as opposed to the nerve which is going to elicit movement. Okay. Okay, so medial and lateral plantar nerve derive from the tibial nerve, but the sural nerve actually derives from the common peroneal nerve, and it is very nicely presented on your slide, on this drawing. Okay, so just you can just simply follow it, and you can clearly see that we are looking at somebody from the front, so it's anterior point of view, right? So you can clearly see that behind the knee, the sciatic nerve divides into the deep peroneal nerve, which goes to the front, and common peroneal nerve, which actually stays in the back of the knee, where the sciatic nerve actually is. Okay, let's go to the next slide. And this is a tibial nerve, right? Tibial nerve. So we got another view, this time from the back of the leg on the tibial nerve. And again, you can see that on this particular drawing, you can see very clearly how the sciatic nerve divides into tibial nerve and common peroneal nerve. And very nicely, you can see over here the sural nerve, which actually primarily comes from the common peroneal nerve, but also on this drawing we can see that got some nerve supply from the tibial nerve as well. And that's pretty much all I want you to kind of realize what you're looking at. On the bottom of that picture, you got also, you can see the terminal branches over there, such as medial plantar nerve and lateral plantar nerve. So this just shows you how this nerve divides itself into terminal branches, and those terminal branches are actually attached to the muscles. Okay. Again, as always, with good comes the bad, right? So we're gonna talk about some deformities and abnormalities people suffer. Pes varus, known as clubfoot, pes valgus, which is the opposite of pes varus, pes cavus. I already mentioned this. This is the high arch of the foot. Pes planus is the opposite, is the flat foot. Hallux valgus, lateral deviation of the first toe. Hallux rigidus, limited motion of the first toe. Claw toes and hammer toes. All right, so let's go to the next slide. So this is pes valgus. Foot goes into pronated position and kind of stays there. You got some degree of inclination of the foot, and you can clearly see that this is a problem because you're putting pressure on your foot on one side when the other side is really decompressed. And you can also observe the ankle that the bones are misaligned. Therefore, of course, there is going to be some stretching of tendons, ligaments, and capsule itself on one side when the other side is really not working and lax. Okay, let's go to the next slide. Those are pictures of real feet, real people, and you can see how dramatic actually this pes valgus condition can get in real life. Okay, let's go to the next slide. Pes varus is the opposite, of course, where the foot is supinated and somehow stays there. The common terminology for that, or we know it as a clubfoot deformity, and of course from an anatomical language is pes varus. And again, you got some pictures of real life people and how dramatic pes varus can actually get. So you can clearly see that people will have difficulties walking, let alone jumping or running. Right, so let's go to the next slide. Pes cavus, abnormally high arch. Maybe congenital, people are born with that condition. Neurological, could be genetic, or due to a muscle imbalance. So where is due to muscle imbalance, therapy can help. We can work on muscles and kind of stabilize that position of that foot. If it's neurological, then of course it's much harder. Depends if the neurons are actually going to heal or not, or if they're gonna heal to what degree. And of course, when they are congenital or genetic, it's not much you can do therapy-wise. But can we help those people? Physical therapies are gonna work, of course, on those external devices, inserts, and all of this stuff. And from occupational therapy point of view, of course, we can issue adaptive equipment on as needed basis, or even without adaptive equipment, we can teach our patients how to perform daily activities regardless of the difficulties or limitations related to the conditions. So it is always something we can do. Okay, and even though sometimes it seems like, oh, this is a typical physical therapy problem, and perhaps you would be right, but remember that dealing with devices such as inserts or any other device, or managing the pain, that's gonna be physical therapy rather than occupational therapy. But remember that those people must perform daily activities. They have to be as independent as possible. So saying that this is a physical therapy rather than occupational therapy really it's inaccurate, because if people need physical therapy, chances are that they need occupational therapy as well. again, from different philosophical point of view. Can you perform daily activities? Can you do this? Can you be safe doing that? And that's occupational therapy. All right, so let's go to the next slide. Pescavos, this time you can see that on the left hand side is a drawing, it's a model of how this foot look like. On the right hand side, I especially found this picture. I googled it and I found that picture. The ancient and not so ancient Chinese women were actually forced to bind their feet very, very tightly, because in Chinese culture, the smaller the foot, the more desirable the woman is. So what it was is that in early stages in life, really since the baby was born, the women's feet were bound with bandages, not allowing the foot to grow, therefore completely distorted the foot. And how did it look like? You can see on the right hand side, this is a picture of a real foot. As you can clearly see, this is a picture. Therefore, I said previously ancient. Yes, this culture is of course very, very ancient. Chinese culture is one of those most ancient cultures on earth. But actually, it went up to 19th century, and we know that by the end of 19th century, we could take already pictures. So this is a real picture of a real person. By the late 19th century, the whole motion of binding teeth is by law prohibited. So right now, of course, that doesn't happen. But who could afford to bind their baby's feet? Of course, a woman with foot, which you can see on the picture, could not walk, period. So who could afford that? Only very, very rich. Those women were married to the rich people. They didn't work. They didn't do anything. They couldn't even walk. So everywhere the woman needed to be, she had to be carried. So of course nowadays that would be absolutely out of question. And in today's culture, of course, a lot of women are actually joined the workforce. So if you couldn't walk, you couldn't do much. And of course, at that time were no computers or telephones to have this type of jobs. Okay, let's get to the next slide. And you can see a very, very short YouTube clip on Pescavos. Some of those clips, or actually all of them, are very, very short. So all you can do, or you should do, is just copy and paste this address, go on YouTube, and just spend few seconds to see real people. Pes planus may be congenital from muscle weakness, ligament laxity, or dropping of talar head. And the dropping of talar head is what you can see on this particular drawing. Talar head displaces medially and plantarwardly, or plantarward, and that's the condition. Okay, so let's go. What else? This condition is also called flat foot. So and that terminology probably everybody heard. Flat foot, pes planus. Okay, let's go to the next slide. Pes planus again. So this is another way of looking at feet. They are of course bent, they are inverted, or inversion, eversion, depending of the condition. What can we expect from the pes planus? Problems with wearing shoes, and you can clearly see that on the right hand side, the sole of the shoe got different thickness on the right hand side and different thickness on the left, and of course that could be a big problem with comfort wearing the shoes because of this constant rubbing of the foot on one side of the shoe. Okay, let's go to the next slide. Pes planus again. I give you a very short clip on the YouTube. Hallux valgus, lateral deviation of the toe. Lateral deviation of the toe happens more often probably than you might think. Arthritis is the big culprit for the hallux valgus. I had actually several older women having that problem. What can we do about it as occupational therapists? Yes, we can. We can educate them about proper footwear. Also, what I personally did on like 2 or 3 occasions, I asked for soft shoes, and then I literally with scissors cut opening in the shoe to allow for that bony protrusions for that great toe to be more comfortable as the lady was wearing her shoes. She allowed me to cut her shoes, of course, and they were the type which I actually could, so that worked out pretty well. So let's go to the next slide. Hallux valgus, lateral deviation of the big toe, and you can see it clearly. This is actual x-ray. The foot which I was helping the lady with, which I just told you about, is cutting off the part of the shoe. Her great toe actually was so bent that actually lay on the top of the toes. So it's like a really bad case of arthritis. So let's go to the next slide. Claw toes. So you can see it on those drawings. It's a hyperextension of metatarsal joints, and flexion at the PIP and DIP gives you that look of the claw, this time not claw hand but claw toes. And again, a short YouTube clip. Hammer toe. Hammer toe is slightly different because you got still hyperextension of metatarsal joints, but this time DIP joint is joints are hyperextended, but PIP joints are flexed, right? So you can clearly see that hammer toe and hammer toe is different than claw toe. Okay, let's go to the next slide. This is what happens when people with those conditions wear shoes, right? So calluses are very common, and calluses can get to the point that if not treated perhaps on daily basis, can get to the point that actually people need surgical removal. Again, the calluses formation you can see in those short YouTube clips. And we got to the next slide, which is called deformities and abnormalities. Pes calcaneus, walking on your heel, and pes equinus, walking on the ball of the foot. Okay? So pes equinus, we also known as drop foot. So your patients post CVA. I saw so many of them that I couldn't even count. Most people with severe enough CVA, the people who are partially paralyzed, they usually have pes equinus or the drop foot. Okay, so pes calcaneus, it's a dorsiflexion, walking on the heel. So in order for us to walk on the heel, the foot has to go up. Therefore dorsiflexion of the foot, right, usually is caused by the injury of the tibial nerve. Okay, so pes equinus, plantar flexion, is at the foot caused by injury to the deep peroneal nerve. And why it happens so often in patients post-CVA? Because the signals from the brain are, of course, distorted, or they are not reaching the destination in the first place, which includes the deep peroneal nerve. If deep peroneal nerve doesn't supply the appropriate muscles, then foot simply drops. Okay. And this concludes this presentation, this discussion of ankle and foot. And we have only one lecture left, so I will see you soon, and thank you. Bye for now.